Hi everybody, Melissa Robertson again, and we are going to discuss Chapter 34, Chronic and Degenerative Neurologic Disorders. So this is a picture of the neuron. Remember, the neuron is just that functional unit, right? That is like your major player in the neurological system. We're going to discuss a couple parts of the neuron. So you have the dendrites. So dendrites, and you can see them in this picture, they're kind of like the ends there, they look like little tree branches. They receive the incoming signals from the body, and then the axon. So you have the axon, you see it here in this picture. And what the axon does is it sends the outgoing signals to other neurons, or it transmits signals. Now there are some axon terminals you'll see at the end of this picture. They look like little branches with a little circle on the end. And so what those do is they release neurotransmitters. Now keep this word in mind because you're going to hear neurotransmitters over again and again. So neurotransmitters are chemicals that transmit signals between the neurons. So some neurotransmitters that you need to get familiar with are like acetylcholine, serotonin, and dopamine. Dopamine is one you are going to hear again when we're talking about Parkinson's. So pay attention to this one. Dopamine affects the person's behavior, their movement, so like their gait, and their posture and their attention span. So these neurotransmitters are really, really important. So you do have three different types of neurons. You have motor neurons, sensory neurons, and interneurons. So what those interneurons do is they connect the sensory and motor neurons. So you see how all of these guys kind of work together. Okay, so what is nerve conduction? This is just the process that electrical signals travel along the neurons. So electrical impulses or electrical signals, those can be interchangeable with the word action potential. So that is something that's in your textbook. So electrical impulses or action potential are the same thing. But this nerve conduction is the process where these electrical impulses will travel along the neuron, and they rely on the movement of ions, those ions that are sodium, potassium, and calcium. So those ions move through these specialized ion channels. That action potential, remember, or that electrical impulse, is generated when those sodium channels open, which causes depolarization. And then that will be followed by potassium channels opening in order to restore the cell's negative charge. So I know that's a lot of words, but that's kind of what happens in a nutshell. It's just this constant process. Remember, your body is always trying to balance everything out. So it's just this constant movement of communication between these neurons. So one thing to note though is that myelin will speed up nerve conduction by allowing that action potential to kind of jump in between these nodes. And then if there's any disruption in those ion channels or in the myelin, that's where we're going to see some of these neurologic conditions. So you always want to get your patient's baseline neurologic status. So you're going to do a neurologic assessment. You'll see in this picture there's the Glasgow Coma Scale. This is one you can do on any patient, but especially one that you suspect any kind of brain injury or anything like that. So the Glasgow Coma Scale is broken down into these categories of eye-opening response, their motor response, and verbal response. You'll see there's a score here. The highest that they can get is 15. The lowest they can get is a 3. So the lower the score, the worse their neurological status is. Now, once you look at your patient, that's where you're going to start assessing them. So you're going to, whenever you just go in and look at them, if they look like they are alert and they know where they're at and what they're, what they're there for, then that will certainly come into play with their level of consciousness, right? So you see this little acronym here, this AVPU. So that is going to be if they are alert, they are aware, right, to where they are, to who or where they're at and who they are. So voice, the patient will respond to any kind of verbal command. To pain, the patient does have a response to painful stimuli. And then the U is if they are unresponsive. So there's no response from the patient. So you're going to be looking at all those areas. Orientation, so are they oriented to person? Do they know who they are? Place, where they are. Time, do they know what year it is? And then the S is going to be for stimulation. Do they know what is, or their situation, I'm sorry. Do they know where they're at and what's going on? So look at their level of consciousness, their orientation. You can use the Glass-Coma scale for sure with any of your patients, but specifically with those who you suspect they have a brain injury. If your patient has any kind of history of head injury, seizures, so if they have seizures, you do want to make sure that if it's a witness seizure, that somebody documents when it started, what was happening right before the seizure, what was happening during the seizure. Was the patient convulsing? Did their oxygen level go down? Did they turn blue or anything like that? So all of that would have to be documented as a part of your assessment. You also want to check the patient's gait. So how are they walking, their posture, their strength. So you want to just squeeze their hand and kind of get a baseline for their strength as well. You also want to assess their speech. So whenever you're asking them these questions, hi, Mrs. Jones, how are you doing today? Can you tell me your date of birth? You want to assess how they are speaking back to you. Is their speech slurred? Are they using the appropriate words for what you're asking them? You also want to know what their normal vision is like. Do they use corrective lenses or not? Are they having any difficulty with their vision? Maybe seeing double, or they can only see out of one eye. What is their hearing, their normal orientation and cognitive status? So what was it like before they were in the hospital? What is it like now? What are you seeing? So all of these things would be a part of your neurological assessment. So with these neurological disorders, there are some common diagnostics you're going to see along the way. MRI and CT scan are very common orders to diagnose a neurologic condition. These are non-invasive, and it gives the provider a chance to actually see the structure of the brain itself. Another one is an angiogram, and that will actually look at the vessels of the brain, the head, the neck. X-ray is another common one. One that you're going to hear later in this lecture is electromyography, and that is where they are looking at the actual electrical activity from the brain and the spinal cord that controls the muscles. So it's kind of looking at how are these muscles being stimulated to move. So just keep that in mind, because some of these are going to come up again as we're going throughout this lecture. Okay, so moving into seizures. So what is a seizure? It is the sudden abnormal discharge of impulses within the brain. So there's an imbalance between those excitatory impulses and the inhibitory impulses. So again, it is just an imbalance between those impulses, and it is just a sudden abnormal firing within the brain. So what do we see? Now, we can see different manifestations. It really depends on what area of the brain is being affected, but you can see an altered level of consciousness. You can see full-on convulsions. The cause may be unknown. Many times with a seizure, they don't know the cause, but if they do know the cause, it could be because of a tumor, an infection, it could be because of a stroke, it could be because of substance abuse, and it could also be because of epilepsy. So during the time of the seizure, the period that the patient is having a seizure, that is called the ictal period. Once that is over with, it's called the postictal period. That is after the seizure. So during that time, the patient might be a little groggy, a little bit confused, but that's the time that they are coming out of that seizure, that seizure-like state. So we're going to move into epilepsy. So this is a neurologic disorder of recurrent seizures. Head trauma is the most common cause in your young people, and stroke is the most common cause of epilepsy in elderly. Many times they don't know what it is. It could be something that is in the family, or they may have nothing that they think is causing it. It may just be of unknown origins. Epilepsy is going to be diagnosed whenever the patient has 2 seizures at least 24 hours apart. So in order to diagnose a seizure, they're going to go off the patient's history. and then they're going to do a CT or an MRI of the brain, and then they're also going to draw blood because they want to rule out any other illnesses or any kind of substance abuse, because remember, some certain substances like extreme use of alcohol or certain drugs can cause the patient to have a seizure. So there's two different types of seizures. There's focal or generalized seizures. So with focal seizures, this involves one hemisphere of the brain. It's local, and the patient is aware during these seizures. And with generalized, it can start in one hemisphere of the brain, but then eventually it's going to involve both. But during a generalized seizure, the patient is not aware. Their awareness is impaired, so they're not aware of what's going on around them. Okay, so I wanted to move into status epilepticus seizure. So this is a medical emergency. So we were just talking about epilepsy, where they're in this seizure-like state. With status epilepticus, this is where they remain in that seizure-like state. It's prolonged seizure activity more than 5 minutes, or they are having more than one seizure in 5 minutes without recovering to normal. So either one of those. So a long-lasting seizure or multiple seizures back to back to back, and they're just staying in that seizure state. They're not returning to normal. So this is a medical emergency. This is something that has to have intervention. So here, your patient's ABCs are the priority. So their airway, their breathing, their circulation. Because during a seizure, they can have times where they're not breathing, where they're turning blue, where their muscles are very rigid. So when they're constantly in that state, their airway will be affected. So this patient, you will be monitoring their vital signs. Some labs that they would want to look at would be glucose. They would want to check their glucose levels, their electrolyte levels, and then there's a CBC, so they can see if there's any underlying infection. So headaches, this is something that you guys have probably all dealt with. There's two different kinds, primary and secondary. So primary headaches are just headaches that have no other illness or trauma along with it. It's just the headache. Secondary is actually caused by something else. So some other primary condition. So like hypertension, a concussion, a tumor, something like that that's actually causing the headache. So primary, we're going to break it down into 3 different types. Primary, you can have a tension headache, migraine, or it's called a TAC, a TAC. We're going to talk about those in a little bit. So we're going to start with tension. So a tension headache can last just a few minutes to even days long. A tension headache is going to usually be bilateral, so on both sides is where the pain is going to be. In order to diagnose a tension headache, it's going to be diagnosed on the patient's history and the clinical findings. So with a migraine is a little bit different. These are periodic, usually throbbing on one side. Patient has photophobia, so that means that they are sensitive to light, and they have nausea and pain along with it. Usually that pain will worsen if the patient is moving, if they go from sitting to standing, if they roll over, when they're vomiting, it's going to get worse. So there are 4 phases for a migraine. But really, to kind of sum it up, hyperexcitability is what we're going to see in the brain. And then this depolarization, remember we were talking about ions earlier, but you're going to see this depolarization of the neuron, and that's going to activate the trigeminal nerve impulses to the brain. And this is what causes all that pain. So you want to find the underlying cause. There's a lot of different triggers for migraines, but it could be emotions, it could be hormones. Maybe in a female, they notice as they get closer to the time of their period starting is when they're going to have migraines. Certain foods, one, unfortunately, is chocolate. Some people can't have chocolate because it will trigger a migraine. So they need to find their triggers to hopefully decrease the migraines. To diagnose these, it is based all off of symptoms. So it's going to be symptomatic to diagnose them. And then the last one are these TACs. So this is also called a cluster headache, but it's actually different. You'll see in your book there are different terms here, but a TAC or cluster headache. So this is usually on one side, so unilateral headache, and you're going to see it involve the eye. They're going to have a lot of pain in the eye. They may have some tearing of one of the eyes, but that's where it's all going to be, and in the temporal area. This could last just a few minutes to maybe 2 or 3 hours, and it's multiple times a day. That's why it's clustered. So it happens throughout the day, and this is also diagnosed off of the patient's symptoms that they present with. So then you have your secondary. So your secondary, remember, is caused by some other condition. So you have sinus issues, right? You guys have probably all had that, where you have sinus pain that your sinuses are full, and then that leads to a headache. Tumor is a very common one. So if there's a tumor, there's only so much room in the skull, so it's going to cause pressure on certain areas of the brain, and that is going to cause a lot of pain. One that I did want to talk about is trigeminal neuralgia. This is irritation of your cranial nerve number 5, and this is a really, really painful condition for your patient. So this is one, you can see it with certain tumors, even with herpes, but it causes very sharp, sporadic pain, and this is very, very, very difficult for the patient. This is a very painful one. All right, we're going to move into Parkinson's. So there's no known cause for Parkinson's disease, but they are linking it possibly to genetics and potentially to exposure to certain chemicals. There are different studies that have looked at farmers, people who have been farmers long term, and the use of different pesticides have been linked to Parkinson's disease. But really, there's no actual pinpointed cause of Parkinson's. So what is it? This is the progressive loss of those dopamine producing cells in the brain. So remember dopamine, we talked about that neurotransmitter earlier. What does it do? It's in charge of movement, right? And posture and your thinking. So that's what we're going to see affected in these patients. So they're going to present with bradykinesia. That's really slow movements. One of the first symptoms they're going to have is a resting tremor or a pill rolling tremor. And that's where you're going to see their index finger and their thumb almost just constantly touching each other, but that is that resting tremor or the pill rolling tremor. Their muscles are very rigid, so you might see them look very tense. This does have a slow onset. It might start on just one side and then move to both sides. Eventually, it will be on both sides. So those are your motor symptoms. There's also non-motor symptoms with Parkinson's. The patient will experience constipation. One that you may have seen is drooling. That's a very common symptom of Parkinson's, and bladder dysfunction and depression. And then to diagnose Parkinson's, there's a little acronym you can use. So they are diagnosed based off of their symptoms, but the acronym is TRAP, T-R-A-P. So T is for tremor at rest. The R is for rigidity. Remember, their muscles are very rigid. A is for akinesia, and B is postural or gait instability. So if you can remember that acronym TRAP, that kind of tells you the symptoms that they have with Parkinson's. Okay, amyotrophic lateral sclerosis, or ALS. So this is one that you may have seen. There's a very famous scientist, Stephen Hawking, who did have this. So you might be familiar with this a little bit. But what is it? It is a progressive neurodegenerative loss of upper and lower motor neurons. So neurodegenerative, that means literally, so those neurons are going to be broken down is what it is. So eventually they're going to lose all control of voluntary movement, and they aren't going to be able to make those voluntary movements at all, including respirations. Eventually they have respiratory failure potentially. There's no cause. There are some risk factors, but there's no actual cause that they can pinpoint. One of the classic signs is painless muscle weakness. So it could be something that, like, they notice it whenever they're trying to pick up, let's say, a can of soda, and they're not able to. That grasp isn't there, or it just falls through their hands, or they're trying to button up their shirt and they're not able to do it. So it's painless muscle weakness and atrophy. Remember, atrophy means like it's getting smaller. So whenever they present to the physician or to the provider, they will have clumsiness. They might have a disturbed gait, so they're not walking very steady. And then there's two different onsets. There's bulbar onset and limb onset that your book talks about. So the limb onset, of course, it affects the limbs, so their grasp is decreased. With that bulbar onset, it's going to be things that affect like their chewing and their swallowing is going to be affected. Remember with this one, there's no cognitive impairment, and that's the hard part. They know what's happening. They know what's going on. They can see it. Their cognition is not affected at all. It is primarily going to be their upper and lower motor neurons. So you're going to see this progress, right? As time goes on, there's no cure for this. It progressively gets worse. So the diagnosis is going to be based on signs and symptoms. They are going to draw labs to kind of, exclude other disorders like thyroid, maybe liver function, kidney function. They're going to look at those things to see if there's anything else going on, and then they'll make the diagnosis based off of their signs and symptoms. But this is one, there is no cure for this, so eventually this patient is going to need respiratory support. They're going to be in a wheelchair, so this is something that would be terminal for them. All right, multiple sclerosis or MS. This is a demyelination disorder. So remember the myelination around that neuron. This is considered an autoimmune disorder. It is a progressive disorder, so that means it progresses over time. There's no underlying cause for this. You'll see in a lot of these neurocognitive disorders, they really don't know what causes it specifically. In this case, it is autoimmune. This is an autoimmune attack on the myelin. So the body is attacking itself. It's attacking its own myelin, and that results in inflammation and damage to the myelin that surrounds the cells in that central nervous system. So that's why you're going to see the symptoms you see in your patient. It does have period of remission and exacerbation. So what that means is while they're in remission, they're not really having any symptoms, or they're very mild symptoms, or they're well controlled or well managed symptoms. But then during a period of exacerbation, those symptoms are really exaggerated. So what kind of symptoms are we going to see? You're going to see things like muscle weakness, numbness, and tingling. The patient will have very poor balance, maybe some vision issues. They might have blurred vision, and fatigue is what they're going to present with. So as this progresses, you do need to be on the lookout for changes in their cognition and dysphagia. So they may have difficulty swallowing as this goes on. So to diagnose this one, they will do an MRI, because they are going to be looking for these plaques that are specific to MS. And then there's something called the McDonald criteria. This just has very specific findings that they are going to match up to the patient. So using those two things along with the patient's presenting signs and symptoms is how they're going to diagnose this. So Huntington's disease is a very tragic disorder. There is no cure for it. It is an inherited disorder, so it is something that genetic testing would need to be involved because it is passed on through family members. So this is an inherited progressive degenerative disorder. So know that word degenerative, because what that means is they are literally losing neurons and brain cells, and that is why you're seeing what you're seeing in your patient. So in this case, you're going to see motor symptoms, cognitive symptoms, all of those things. So there are involuntary motor symptoms. You're going to see the term chorea, C-H-O-R-E-A. That is these irregular dance-like movements that they have. They are involuntary. They cannot control it. You're also going to see athetosis, which is kind of like a twisting motion for this patient. There is going to be cognitive decline, and then emotional and behavioral symptoms. They're going to have a lot of changing emotions, especially as this progresses, and if they have seen other family members with it, because remember, this is hereditary, so they may have seen a grandparent or a parent or a sibling suffer the same things. So depression is something that is very common with this disorder, because it comes with it as the brain, goes further and further into dysfunction, but also because they have seen what it has done to other family members potentially. So they could have slurred speech. You're going to see a history of this in the family, as I said previously, and eventually these patients are going to lose all function. They're not going to be able to go to the bathroom on their own. They're going to lose all functions up until they eventually will pass away from this. All right, so this is Guillain-Barré syndrome. This is one that was in the news a lot during COVID because they were saying that this was from some of the vaccines. But Guillain-Barré syndrome is actually a post-infectious autoimmune response. So this can happen after an illness, usually from cytomegalovirus or Epstein-Barr virus. They've been exposed to that. It could be from a respiratory virus. And then you can see this after certain vaccines. So this is something that does happen after vaccination. It's rare, it's not common, but it does happen. So this is a post-infectious, that's a really important thing to remember, post-infectious autoimmune response of peripheral neuropathy leading to progressive limb weakness. And this happens over days or weeks. So what this is your body is attacking itself in the nervous system, and it's going to start from the bottom up. So progressive limb weakness, it starts from the feet and moves its way up. So it is symmetrical muscle weakness that begins in the legs and ascends. It goes up. So that is what kind of sets this apart. So how does the patient present? So they're going to have that symmetrical muscle weakness. They may have paresthesia, so that tingling or numbness. And it can vary from very mild weakness and tingling to complete paralysis. And that it can include the respiratory muscles. That's why this is so dangerous. Because if it does go up to paralyze those respiratory muscles, then this patient is going to have to be ventilated or need respiratory support of some kind. So in order to diagnose this, they are going to have to draw some labs. Remember, I was talking about a lumbar puncture. So in this case, the patient would need a lumbar puncture, and that cerebrospinal fluid would show an increase of proteins. They would also do electromyography of the affected limbs, so they can actually look at the conduction in the muscles, what the strength looks like, how those impulses are being communicated to the muscles. So they're going to look at all of that in order to make a diagnosis. So this can last days or weeks. It just depends. Some people, though, recovery can take a very long time, months, even a year or 2 years. It can be very lengthy depending on how severe the case is. Okay, myasthenia gravis. So this is another autoimmune disorder. So the body is attacking itself, and this is where they have lost the functioning of acetylcholine at the receptor site. So the body is actually producing antibodies against acetylcholine. So that is what the issue is. There's two forms of myasthenia gravis. One is ocular, so it affects those eyelids. So the term ptosis or diplopia, so it's like a drooping lid. And then the other kind is general. So a patient can start with ocular and move into general. So this is where they have not only the eyes that are affected, but also limbs and their respiratory muscles. So that's where it becomes dangerous. So this patient will present with that muscle weakness of the limbs, maybe the eyes, depending on what kind it is. But there is something called a myasthenic crisis. So this is where there's some kind of stressor in the patient's life. It could be an illness, it could be something stressful happening, it could be surgery, whatever it is, and it's going to worsen these symptoms. So this patient could potentially need respiratory support, because remember, this affects the respiratory muscles. So if they're in this crisis state, they can actually go into respiratory failure, and that would be very dangerous for this patient. So this is just diagnosed on their history, on their presenting symptoms, and then if they have those antibodies for the acetylcholine. All right, we are going to finish up with a patient, Mr. John Thomas. He's 36 years old, no significant medical history other than a mild viral infection 2 weeks ago. So there's your clue. He has progressive weakness and tingling in his feet and legs, which started about 3 days ago. He thought it was just muscle fatigue from working long hours, but over the past 48 hours, it has spread upward. There's another clue, affecting his hips and upper limbs. He's now struggling to walk, and he cannot climb stairs, as well as having difficulty breathing and difficulty swallowing. His speech is a bit slurred, but he doesn't have a sore throat or any other respiratory symptoms and denies pain. So putting those symptoms together, we can conclude that Mr. Thomas may have Guillain-Barré syndrome, or GBS is what it's going to be abbreviated as here. So how do you differentiate between GBS and other conditions that cause muscle weakness, such as stroke or myopathies? So in this case, how would we do that? So think about how this is diagnosed. Remember, he would have to have a lumbar puncture. That lumbar puncture would be diagnostic because he would have elevated proteins in that cerebrospinal fluid. Another thing they could do, and he would probably have a CT scan of his brain as well to rule out a stroke, to make sure that there's nothing going on in there. And then they would look at his muscle strength. Remember that electromyography, to look at the conduction happening within the muscles. So that is how they would be able to differentiate between GBS and other conditions. So what are the characteristic features of Guillain-Barré syndrome? So remember, he had a history of a viral infection, and in this case, it was like the flu. He has progressive weakness and tingling that started in his feet, and it's moving up. Now he's having difficulty breathing and swallowing, so it's moving up. So how does this ascending pattern of paralysis differentiate it from other neurological conditions? So in this case, that ascending pattern of paralysis is very specific to GBS. The other neurologic conditions that we discussed is progressive, but in the opposite way. It will start more in the limbs, maybe the fingers, something like that, in the muscles in the hands. But with Guillain-Barré syndrome, it does start from the bottom and go up, so it's an ascending pattern.